We're excited to be here with you today. Thanks to you all that are staying. I know it's a beautiful day out there, but we promise to have a really exciting and provocative discussion here. So I'm going to ask the panelists to introduce themselves. So we can start to my right with Nolie.
Okay, hi. I'm Nolie Barnes, and I'm a principal with DHG Healthcare. DHG Healthcare is a advisory service, healthcare advisory services across the United States. We actually, you may know us as Tax and Assurance Work. We also have 12 offices in 12 states, and we have our new office in downtown Richmond. We're happy to be downtown now, and I'm happy to be a part of DHG Healthcare. I actually have over 25 years experience in healthcare. I'm a nurse by training and have spent the majority of my career developing outpatient access points, physician alignment strategies, and most recently, employer outreach. I joined DHG to lead our charge towards alignment with employers and health systems across the country. Thank you.
Great. Hello, everybody. Good afternoon. I'm Lauri Rustand. I actually serve in two capacities currently. I've been the CEO of Fairfax Family Practice Centers, which is a large family medicine group in Northern Virginia, about 130 providers. It's been around for about 40 years and has also affiliated with, we have a residency training program through VCU. And then in the past 6 to 9 months, I have added another capacity, or another hat. We joined a company called Privia Health last year, and I am serving now as the market president for this market, which is Virginia, Maryland, and DC. And Privia Health and Privia Medical Group is sort of a relatively new group that's been formed, frankly, over the last only 2 years, and we have grown. We focus on primary care and, believe it or not, pop health. We've been hearing this all day today. We're about 1,000 doctors already in 2 years, and we're growing. We bring actually practices on board every Tuesday on a new platform, new tools. We're there. We're kind of like the, you look at a doctor, a PCP, and all this stuff that they now want a primary care doctor to do. And they don't have the time to do any of that, to be honest with you, especially in your 15-minute visit. So we're kind of a designed medical group with the sole purpose of to help primary care physicians deal with this new world of value-based payments, and then also try to, if you think of the doctor as the coach, maybe the health coach or the quarterback, we're gonna be the rest of the team that's gonna surround them with both tools and data and people to try to solve for this, because this is a journey. We're definitely not there, and we've got a lot of work ahead of us, but I'm excited to be here, part of that journey.
Good afternoon. I'm Adrian Stanton. I'm Vice President and Chief Marketing Officer of Virginia Hospital Center. We're one of the Commonwealth's only standalone hospitals. I guess probably one of the few in the Eastern Seaboard. We're a 350-bed facility located in the suburbs of Washington, D.C. and Arlington.
Great. So we're going to get right into some of the discussion here. Healthcare data can be a key component for company executives to consider when making decisions that impact the health and wellness of their employees. Nolie, can you talk about what data should be considered and how it can create innovative and meaningful solutions to improve the health and productivity of a workforce?
Yeah, I think, well, clearly we've heard today, data's big. Employers have access to more data today than in the past. It's clearly making sense of that data. I think everybody in this room knows roughly 75% of healthcare spend is on chronic conditions. And so really being able to move toward preventive care and using healthcare dollars in that way really requires rethinking and using healthcare data, both complete, robust, and transparent data in making actionable decisions around programs, around provider alignment, and really needing that data in order to do it. I think we've heard really innovative solutions today, but frankly, most employers still sit in a position where it's very challenging to make sense of what data they do have. There's a lot of information out there, and what is it that they need to use to create innovative solutions. And I think really taking data to being able to predict illness or predict emerging conditions versus treating illness is really where they want to go. I think that's the goal of this.
Mm-hmm. So a big focus of healthcare reform is the transparency of data in terms of quality and cost. Adrian, how can healthcare transparency help organizations, their employees, make informed, personalized decisions that address quality as well as cost of care?
I'll do this with a quick story that I think is appropriate for this gathering here. In 1998, there was a group of business leaders that got together to form a group called the Leapfrog Group. That group was dealing with the high cost of healthcare as it impacted their businesses, and they thought by bringing in transparent data, they could make changes to the quality, safety, and cost of healthcare. That group just recently released a report that said on an annual basis, 440,000 people die a year in hospitals from preventable errors. That makes us third behind cancer and heart disease. We can do better, we need to do better, and I think what we need, and I think that's where transparency of information has already gotten us there in the last couple of years. That transparency of information, which has flooded to us, has created huge changes for us from a quality perspective. We have less readmissions to hospitals. We are doing a better job of identifying illnesses on the front end and trying to keep people out of hospitals. But if I can steal a line from Dr. Hazel and from the presentations today, we need your help. And I think we need your help not only in putting that transparent data in front of us, but telling us what is important to you, and then I guess taking that a step further, there's this incredible knowledge base that you have about how to use that information from a technology perspective. And as you've heard from some of the presentations, we're in the infancy of using that technology, and we need that help to further that along, which I think will ultimately end up in making us have better quality care, safer quality care, and frankly, more cost-efficient care.
You want to go ahead, Nora?
I think that makes great sense. And from my perspective, having been across the country and working with large employers, it is much easier to find hospital-based quality data as an employer trying to drive value and look for value. There's the ability to see transparent data from hospitals, both from CMS, from the Leapfrog Group. But as you're trying to build health plan designs around ambulatory care and by physician, it's very difficult to find, as someone mentioned earlier, it's easier to find out a rating of a restaurant than it really is to provide quality data around a provider. Mm-hmm. So a real example I've had recently is working with a group trying to refine their provider network. They work with their TPA or their payer, but it still is very challenging to figure out where are the quality physicians that I might align my employees with. People will ask personal recommendations, but that's really not the best way to create plan design and drive value to physicians. I think, Lauri, you probably have experience.
I don't disagree with you. I would say less than 5 years ago, primary care, actually any provider really didn't have access to any comparable data, even about themselves, compared to their peers. The insurance companies had some, and I would say hospitals have some if you do your work in a hospital. But when you think about private practice and where most of us get our care at a doctor's office, there wasn't a lot of data collected, if you will, from that encounter except what we call claims data, right? The ICD-9, ICD-10, disease descriptions. But really, that doesn't explain what happened during that encounter. It just doesn't explain it. So we've been spending a whole lot of time. You can imagine the data that is now available to doctors to start looking at this, and we're spending a lot of time and money trying to figure this out. And now we have dashboards by doctor. I mean, one of the reasons we joined Privia is because we did not have the data analytics tool to start looking monthly at metrics and quality outcomes and trying to say, well, what should we really be looking at? You know, how do you even measure, I mean, what's an outcome of a primary care visit? It really is long-term measuring how somebody stays healthy. Well, that's multi-year, multifactorial information that we're all grappling with today, trying to figure out how to measure that. So we're doing it, we're starting it, but we're not there yet by any stretch. And I'm hoping that we will get a lot more information out on a regular basis. I think the federal government's doing actually a pretty amazing job in trying to throw some of this information out there. We're just not sure what to do with it all.
Right. Interesting. Nolie, in your work with DHG Healthcare, you help align employers and healthcare providers to address healthcare for the workforce. You mentioned that. Why is healthcare data so important to employers, and what challenges do they face regarding the acquisition and use of healthcare data?
Well, I think we've all commented, we've heard lots about why it's important, so I'll jump into the challenges. So what we see, and it does vary by employer, but in general, the big key decisions around healthcare data and financial decisions are made by CFOs, by finance people, HR people who have some understanding of healthcare, but clearly we all find this perplexing, and most of us have worked in healthcare for quite some time, and then trying to really understand that data without a healthcare background and how to create meaningful solutions from that to drive wise financial decisions is very challenging. It is something that I think working with others, with consultants, with their payers to try to make sense out of that data to drive actionable solutions is something that is a challenge, remains a challenge.
You know, I'll add a little bit on that too. I think part of the opportunity here is for businesses with their health benefit designs, with their wellness programs, to help bridge the information gap and the education gap with providers. We don't link up very well together right now, and we've got to figure out really unique ways to get, you know, I would say our patients involved, but people aren't patients, we're people. And we're trying even not to use the word patients, because in primary care, we're really trying to keep people not from becoming a patient. So we're really trying to come up with creative solutions. We're working with a couple employer groups now, payer groups, to try to rethink how we engage our patients, but even giving them incentives through a benefit design, through some kind of, you know, we all use the word carrots and sticks, and that's really the world we're in. I would say a lot of the carrots is peer pressure. All these new apps that are coming out, all this, people really do get affected by that. Our employees are constantly competing against themselves now on these different apps, on, you know, well, I'm gonna lose 5 pounds before you, well, no, I'm gonna do that. And you can actually do that virtually now in the world. It's just amazing. And I think those things are really beginning to make a difference, but it comes down to what you feel is normal health. If people think normal health is, you know, somebody that has all these chronic diseases, we're gonna have a bigger problem. But I think people are starting to redefine it. The millennials are actually starting to redefine how you say, well, what's a healthy state and what makes you stay healthy?
Yeah, and I'll just add on to that. Our work with corporations has been centered around looking at data that's coming out about their healthcare costs, where they're spending it, and identifying where their high-risk areas are. And what that's meant to the organization, it's allowed them to restructure their benefit plan to better suit their employee population, to identify where they were at risk or to identify where they were at need. And that has been dramatic, rather than just sort of saying, well, it's one plan only. It has really allowed them to refine their benefit plan.
Yeah, and I'll add one more thing with that. Excuse me. The getting access to a primary care doctor with these high deductible health plans is becoming more of a challenge, because if you're a relatively healthy person, you maybe go get your physical every year, but probably every 2 years, right? If you've got a cold, if you've got a high deductible health plan, you're not gonna spend $150 to come see your primary care doctor when you can go to the urgent care clinic and maybe think you're only going to spend $70. I don't know, those numbers are rough. But my point is, in the benefits design, I think we're fragmenting this access to what I call the relationship between the doctor and the patient. We need that long-term relationship to form over time. I want only copays applied to PCPs, not the high deductibles, because if you just have a $25 or $50 copay, and maybe you have a $500 deductible to go to the emergency room, and if we can provide the access points, which is critical. I mean, you can't do this if I'm not available or the doctors aren't available. So you need access points and you need information at the time of care, and it is going to be multi-access points. It's going to be telehealth, it's going to be walk-in clinics, it's going to be an after hours, it's going to be physicals on demand kind of thing, because that's what we need to meet all of those points. So I think we're starting to do that, and when we can combine that with benefit design, I think we can go a long way for creating the incentive to create a relationship. Because at the end of the day, once something happens to you physically and some disease comes upon you or you have an acute event, you want to be able to feel you can pick up the phone and call your doctor and he can help you or she can help you through that episode that hopes get you better back to the state of health of whatever you like. So that's great.
So, Lauri, from your perspective, you obviously work with physicians that ultimately deliver the care. What new data and information is available to physicians today that is improving their ability to manage the health of individuals?
You've heard it today. There's tons of new data. 5 years ago, we didn't look at anything. We didn't have claims data. We didn't have pop health data. We didn't have information from the employers. Now we have all of that. Some of these new ACO contracts that we have, they're feeding primary care groups claims data. And they're saying, here, take all of this terabyte of data and do something with it. So we're building data warehouses. We're looking at disease registries. We're trying to do what all these mathematicians are trying to figure out, which is to take all this information, put it at the point of a workflow change, at the point of care. And that is a massive change because everybody said, I think you're with your primary care doctor 10 or 15 minutes, and you expect them to manage everything in 10 minutes? We don't do that anymore. We have to now do the 365, 24/7. Well, we've got other teams that have to be developed to manage that, and then people have to figure out a way to pay for that. That is prevention. That's not what we get paid for today. And so there is truly some payment reform that has to come with that. And a lot of health systems are investing in a lot of this information, but we're actually not getting paid for that right now.
I do think I'd add on to that, another key piece of data and information needed by physicians is really quality data on other physicians. So as a primary care physician, they have opportunity to refer to multiple specialists or for specialty care across the continuum. And as a primary care physician, if I'm responsible for the overall health and wellness and the spend on that employee, I really have to understand where I'm referring them for care. And long gone are the days where primary care develops relationships inside the hospital with specialty providers. So really having data that tells them the outcome and the cost by specialty care is very significant as they become the managers of population health and of employee well-being.
Well, and we're getting that data now. And we've got actually a new tool that we've just put in our EMR that tells the primary care doctor it's a referral management tool. And it actually rates, I shouldn't say rates, but we have yellow, green, and red in terms of referring options. Not that you can't refer, but we give them cost data when we have it. And we're getting this primarily, frankly, from the payer community. But they've got some quality metrics also. So we're trying to put that actually at the point of care, that the doctors can actually look at that and say, well, you have three choices. You can go A, B, or C, and here's the options. And I'll go look at our portal, by the way, because we also have linked to the payer that, let's say it's Anthem or Cigna. Go look at our portal. We link to the payer's portal, and they'll give you all the cost data on these three choices. So we're trying to make it simple and more effective with the patient, because I tell you, I think the patients now probably, we've gone from filling out forms to portals. A person with chronic disease probably has 10 portals they got to get into, because every physician group has a portal, every hospital has a portal, the insurance companies have a portal, and now the employers might have a portal. So who's going to do that? No one's going to go look in all these portals. So we've really got to address that.
Great.
Anyone want to add to that?
Yeah. Agreed. Agreed.
So the health plans have access to a huge amount of data for any given workforce. Nolie, how have you seen innovative employers use this data to create custom solutions for their health plan?
I think certainly we've heard examples today around prevention and using data to drive meaningful preventive programs, from care and disease management, things that will drive improved health outcomes and lower costs. Centers of Excellence, another one, using high volume, high cost services. And then, but an innovative thing around this is you see Centers of Excellence done on a national level, where the Lowe's example, the Walmart, that are going elsewhere for, or to national providers of care for joint replacement, let's say. But there's really a way to do that more on a regional and a local level, so we're not exporting our care out of the state. We certainly have very high quality facilities and providers in Virginia. So looking at more local centers of excellence, you're seeing some of that go on across the country as well as national. But I think the example that comes to my mind, I'm working with a Fortune 400 company who has been very innovative, tried to work with health systems to develop more customized provider networks and their TPA, and was not successful. And so over the last year have worked very hard to create a customized provider network, a more narrowed network that meets the needs of their workforce. There are about 35,000 employees in 3 key regions of the country, and then implementing on-site clinics, which is not necessarily new and innovative, but what they've done there is create care and disease management programs within these clinics. They've, to Lauri's point, they've changed health plan design to drive care into these clinics, and then again continue to use robust data to refine the provider network and the services that they're implementing to drive outcomes and lower costs. So it's been a very innovative approach. They are very aggressive. They were tired of talking about this and waiting for health systems to bring about the change, and so they have driven that within their own markets. And it's been interesting to watch, and will continue to be refined, I'm sure.
Well, I think as much as I know about it, the interesting piece about that, and you alluded to it, it isn't just about cost. It's about value. So it incorporates not only the cost-effective or cost-efficient providers of healthcare, but also those that are providing top outcome or quality as well as service. So it kind of fits all those in and truly is trying to put together a true value to businesses. And I'm encouraged to hear that there are so many businesses that are aggressively taking that focus on and doing something about it rather than waiting for it to happen to them.
Yeah.
Absolutely. So Adrian, in this emerging environment of value-based care, what are the opportunities for innovative solutions to manage healthcare costs, provide benefits that help recruit and retain top talent, and promote a healthier workforce?
Well, anybody, all of us are, even if you're in the healthcare side, you're a business, and we're a self-insured organization that has 3,000 employees, and one of our biggest costs on an annual basis is providing healthcare for our employers. But it's a valuable investment because that is our most important asset, and their long-term health is critical to that. So it is, how do we, if it gets to a point, frankly, that they're going into the hospital, that's the worst case scenario. In the scope of healthcare, we represent the most expensive part of the delivery of healthcare. For us to be an effective manager of the wellness of our employees, we have to be aggressive on the front end, which is how do we keep them from experiencing the most critical form of healthcare, the most expensive form of healthcare. So our focus actually has been on the wellness side of it, and we've taken that piece to our corporate partners, and in simple, if you will, things like screenings, health fairs, et cetera, lead to not only healthy alternatives, but it's led to a massive information data that we've been able to work with corporate entities to identify where are those trouble spots, where are the potentials, what are the screening things that come up that identify potential chronic illness, which represents the largest cost of healthcare, and can we do something about it before it gets to that point? And that's where we've seen most of the innovative solutions coming, is partnering with those businesses to share that information, to use their expertise of how to mine that information, and ultimately to develop plans that address the wellness versus how do we address the acute care side of things.
Great.
Yeah, I mean, I'll add that. Just think about the math of one admission that's been avoided through better outpatient care, you know, $25,000, $50,000. In a primary care setting or an urgent care, we can provide a lot of care for $25,000. When you think about some of the preventive work that we're doing now, you know, we're getting paid on average $2 per patient per month, $24 a year. That's what we're getting paid. It costs a lot more than $24 a year, but my point is we avoid one admission for the right reasons and provide the best care, and hopefully they don't get sick enough to ever need that admission. That's a huge savings. So that's kind of where we're focusing a lot of our attention now, is on prevention, wellness. We've got a new tool at our disposal with a lot of this risk stratification stuff that everybody's talking about. We actually, based on the patient's risk score that we can get from various places now, plus based on their insurance, because some people don't pay for this, so we're not going to offer a lot of these screening and wellness programs and prevention programs if we don't get some kind of funding for it. But we've got a way to now risk stratify our patients, kind of classify them into work sets, and the ones that are highly stratified, very complex patients, we actually now proactively call them and try to get them in. We never did proactive anything 3 years ago, nothing. And so we really are now targeting these people, and we're trying to work with, whether it be their employers sometimes, depending on, you know, if they're not working right now, maybe they're that sick. And I think we're really trying to really be proactive with those patients, with their care teams, and with their people that are helping them get back on this road of recovery. So that's probably the biggest takeaway that I would say for physicians. We're actually looking at being proactive more than we used to. Big change.
That's great. All right, so we've got a couple of minutes left. We are going to transition to our lightning round. So I'm going to ask a question, and just if each of the panelists could address it in one sentence or less, that would be great. So what is the first step an employer should take to better understand the health data of their workforce? You want to start, Nolie?
I think really digging into their data, using their payer, their TPA, their consultant, the third-party data warehouse to really dig into the data and understand it and ask questions about it, and really push to get the answers that they need to make wise economic decisions.
Yeah, you know, these personal health assessments that a lot of the wellness programs have put together, that's probably a good start, because you start using that information. You try to get the employee engaged on doing that. They get a little bit more in tune with where they are. You feed that to your doctor and try to get the relationship going. That's one thing that's kind of missing right now, but we're working on that. So I think I would say.
Yeah, I'd simply say there's a lot of data that's coming at you. Just try to understand exactly what it is. There's a lot of terms that may mean something, or you think they mean something, and it's completely different. So understand what you're looking at.
Great. I think we've got about a minute left. We have time for the last lightning round question. What is the number one opportunity for data to help drive a healthier workforce?
Transparency. There are a lot of opportunity, but you've got to be able to, we've got to get to a point where that data is transparent across all stakeholders and that it's shared.
Well, I would say data turning into information, and so that we can use it and absorb it and make effective care decisions with the person that we're treating.
Yeah, I'd echo that. I think the only thing I'd add is that it truly will help you make decisions, harnessing that to, whether it's to benefit plan design or it's just in dealing with the cost and quality of the care you're providing to your employees. It's there, it's helpful, it's just understanding.
All right. Well, thank you all. It's been a great discussion. Thank you all for staying. And
Yes.
Thank you, Barry, and the Chamber staff for another great healthcare conference. Appreciate it.
Let's give them a round of applause. Thank you, Anna. And thank you all for staying, and thank you for participating this year. We hope you found this thought-provoking. I think working together, we will make Virginia healthier and have a brighter future. We will look forward to working with you on Blueprint Virginia 2021, and we will be in touch as those plans unfold. But thank you all very much for attending, and we'll stand adjourned. Enjoy the rest of this day. Thank you.